Okay, here. Okay. Very interesting meeting, and I will give you an overview on Charcot-Marie-Tooth disease, which is, as Jose said, the most frequent hereditary neuromuscular disorder. In Europe, we estimated that there are more than 300,000 cases. And now more than 50 genes have been identified in association with CMT, many during the last 3-4 years, thanks to next generation sequencing technology. And CMT is due to many different pathomechanisms, and some of them are very interesting, and all of them lead to distal axonal degeneration, causing length-dependent peripheral neuropathy, which is the characteristic of CMT. And it starts with the muscle wasting and weakness, which starts from the intrinsic foot muscles, which is the basis for the foot deformities, as nicely shown by Jose Berciano in some papers. And the foot becomes cavus and with hammer tooth, and later on we have tendon length shortening of the Achilles tendon, and then the muscle wasting weakness slowly ascend to involve the leg muscles and the lower third of the thigh, and also the hands with weakness and wasting, and in the most severe cases also the proximal muscles may be involved. The patient usually have decreased or absent deep tendon reflexes. Sensory loss may be present and usually starts from the distal part of the extremities and slowly ascend. And about 1/3 of the patient may develop some degree of scoliosis. The disease usually starts early in life. Most patients start within the age of 20. Then the disease runs a chronic course with very slow progression over years and decades, and usually not causing severe loss of motor ability. And however, there is variability of disease expression, and the severity may vary considerably between families, and this is understandable because many different genes are causing CMT, so may be associated with different disease severity, but the disease may be differently severe within the same family for the same mutation, and this is a matter for research and for investigation. And sometimes the disease is more severe, and patient lose the ambulation capacity, and in an increasing number of patients, we do see now that the disease may have onset later in life, in middle age, and sometimes very late in life, even as late as 70 or 80 years of age. And this is seen increasingly with the spread of genetic test availability. All inheritance pattern, Mendelian inheritance pattern, have been described. Most cases are autosomal dominantly transmitted. There are some forms that has X-linked inheritance, particularly one is frequent, and autosomal recessive forms are less common but are more severe, usually with early onset. Sporadic cases are rather frequent, maybe to de novo mutations, and are a challenge for diagnosis. As I mentioned before, many different genes are involved in CMT. CMT may be associated with mutation in more than 50 genes, encoding proteins involved in many different pathways in the mind, in the axon, in the cell body. And for instance, one important cause is mutation in protein involved in information maintenance of myelin, such as peripheral myelin protein P22 and myelin protein 0, but also channels and gap junctions like GJB1 in non-compact myelin, endoplasmic reticulum stress response like Hirschsprung proteins, BSCL2, Mitochondrial metabolism derangement is an increasing cause of CMT, mitochondrial CMT, particularly abnormalities of mitochondrial dynamics are associated with different forms of CMT. And another important cause of CMT is derangement of the cytoskeleton and of the axonal transport, like in other disorders. For instance, neurofilament light gene is involved, or dynamin 2, or one subunit of dynein, dynactin, and kinesin as well. And also membrane trafficking causing disorder of vesicle trafficking is another important cause of CMT. Many different genes are involved in these pathways. All of them have a final common pathway, whether there is a primary myelinopathy, a primary axonopathy. The final pathway is axonal degeneration, usually involving first and mostly the longest and largest fibers with the length-dependent neuropathy. So the phenotype is usually rather typical. If there is a family history, diagnosis is rather simple. Sporadic cases are challenges, I told you. And then it's important to define the inheritance pattern and to perform nerve conduction studies. At this point, you have all the elements to ask for genetic testing. And the nerve biopsy now is limited to very selected cases. This is a simplification, a representation of the current classification of CMT. The ovals represent the category of subtype of CMT, and the boxes represent the genes associated with each subtype. And this is an old slide. There are many more genes now, but they are difficult to pack all together. However, the first important subdivision, fundamental, is between demyelinating CMT and axonal CMT. Demyelinating CMT is indicated as CMT1 when autosomal dominant and CMT4 when autosomal recessive, and this is oval. It is characterized by slow nerve conduction velocities, and if you take a nerve biopsy, if you look at the pathology, you will find myelin abnormalities, usually onion bulb formations. The other important form is the axonal type, that is indicated as CMT type 2, CMT2, usually autosomal dominant, less commonly autosomal recessive in this area, and is characterized by preserved nerve conduction velocities or only mildly slow nerve conduction velocities. If you look at the pathology, you will find evidence of axonal degeneration. This is a fundamental subdivision, clinically very useful, but there are increasing number of exceptions to this rule because there are forms in between, the so-called intermediate forms. The main one is CMTX, the X-linked variety. Particularly males have intermediate nerve conduction velocities. And there are other subtypes of CMT that are characterized by intermediate nerve conduction velocities, either dominant and less commonly recessive, that is usually caused by a mixture of axonal and demyelinating features. And then we have a pure motor variety of CMT. There is no sensory involvement clinically, electrophysiologically, and pathologically, just motor involvement, distal motor involvement, and they are called distal hereditary motor neuropathy in this oval. And we have some complicated forms. One is CMT plus pyramidal involvement from increased tendon reflexes to overt spastic paraplegia. And now there is an increasing amount of cases causing an overlap between this form of CMT and the hereditary spastic paraplegia, and there are some genes causing both of them. And then finally we have CMT plus optic atrophy that is indicated as CMT type 6. And we will see that we can make a genetic diagnosis in about 2/3 of the patients with CMT nowadays almost 70% of the cases. And the vast majority of these 70% of the cases are due to mutation in 5-6 genes. The most important is the duplication of PMP22. Then we have myelin protein 0, GJB1 encoding connexin 32 associated with the CMTX variety, mitofusin 2, which is the most important gene for the axonal type, and the GDAP1 is important both for dominant and recessive forms, and is particularly important here in Spain because there is a founder mutation here in Spain, and several cases reported, as you probably know, and you have described, some of you have described. And eventually also CNT4 type C, this gene is appeared to be quite frequent for recessive demyelinating types. But 5 or 6 genes are the fundamental ones. And let's see the main forms one. Compact myelin, structural protein of the compact myelin, PMP22 is very important. The application is associated with the most frequent type of CMT, named CMT1A, accounting for about 1/2 of all CMT cases. It is usually cause mild to moderate neuropathy. However, severity is variable with almost asymptomatic patients, together with a few severely affected patients. And there is an ongoing search for modifier genes, which is an important research because it may identify targets for therapy. Conduction velocities are dramatically slowed, and the nerve biopsy showed the typical onion bulb carpet. It's important to remember that the reciprocal deletion of PMP22 is associated with a less severe neuropathy, that is hereditary neuropathy with liability to pressure pulses, indicating that the regulation of the expression of PMP22, the quantitative expression of PMP22 is very important. Overexpression causes neuropathy, underexpression causes neuropathy, so there must be a strict level. Myelin protein 0 is the most abundant protein of the compact myelin. More than 100 mutations have been described in association with CMT. Many of them are associated with a demyelinating neuropathy, usually of early onset, different severity ranging from severe congenital hypomyelinating to less severe CMT, very similar to CMT1A associated with the duplication. It's very interesting that an increasing number of mutations now are associated with axonal neuropathy, CMT type 2, usually of later onset after age 40, 50, even 70 or 80, and sometimes running a severe course. The reason why myelin protein is associated with axonal neuropathy is entirely unknown. Another important protein is gap junction protein, GJB1, is located in non-compact myelin of the paranodal region of Smith-Lanterman incisors, allows the exchange of small molecules and ions between different layers of the Schwann cells. It is associated with the CMTX1 on chromosome X. It's the second most common form of CMT, accounting for about 10% of all CMT types. There's no male-to-male transmission because X-linked. Males are more severely affected. Usually males have intermediate nerve conduction velocities and females have normal conduction velocity in the CMT type 2 range. It may mimic acquired neuropathy because conduction slowing is non-uniform, may mimic CIDP. And the protein, connexin 32, is expressed also in oligodendrocytes. So this patient, particularly males, have subclinical involvement of the central nervous system, as revealed by abnormal evoked potential studies, particularly the brainstem auditory. The central components are delayed, and some patients do develop overt symptoms of CNS involvement, sometimes dramatically, And they may have hemiparesis, sensory deficit, ataxia, dizziness, diplopia, sometimes coma, and they usually recover in a few days or weeks, and mimicking a stroke-like episodes of acute disseminated encephalomyelitis, because they very often have abnormalities of the white matter, particularly in the posterior regions, but not only. And this is a patient we observed at the age of 30 with clear-cut CMT, and he had at the age of 16 these 3 episodes of very severe CNS involvement lasting few hours, with complete recovery in the following days, with this MRI, which was entirely normal a few months later. We suspected CMTX in this case. At that time, the neuropathy was negligible, and he was thought to have acute disseminated encephalomyelopathy, but this is CMTX. He has a mutation in connexin 32. Mitofusin 2 is also very interesting. It is located in the outer membrane of the mitochondria, and it's involved in the process of fusion and fission of mitochondria that is named mitochondrial dynamics, which is important for regulating the, as you know, the size, number, and shape of mitochondria. And mitofusin 2 is important for fusion, but also for the interaction with the Miro-Milton complex and the interaction with the kinesin involved in the anterograde transport of mitochondria. And this is probably the mechanism by which mutation in mitofusin 2 alter transport of mitochondria and lead to a length-dependent axonal neuropathy. Indeed, mitofusin 2 is the most common cause of autosomal dominant CMT type 2. About 10–20% of CN22 cases are due to mutation in this protein. Usually these patients have early onset and severe course, but other cases have a later onset and milder, so it's quite different severity of phenotype. And about 10% of them developed optic atrophy, sometimes suddenly, like Leber optic atrophy, in other cases slowly progressive optic atrophy. And this is understandable, taking into account the function of mitofusin 2. Other patients have pyramidal involvement, and a few others have very complex phenotypes overlapping with mitochondrial disease. Indeed, mitochondrial dynamics are an important cause of CMT, because also GDAP1 is involved in the mitochondrial fusion and fission, is located in the outer mitochondrial membrane, and also OPA1, optic atrophy 1 gene, account for the main form of dominant optic atrophy. 20% of these patients have peripheral neuropathy. And also there are other causes of CMT in the mitochondrial metabolism alteration. There are mutations in the subunit 6 of the complex 5 of the respiratory chain that are associated with the CMT-like presentation. Very recently, children with demyelinating CMT were shown to have a mutation in SIRF1 together with other central nervous system manifestations. But the presentation was with CMT, and also it may happen for disorders of mitochondrial DNA replication maintenance. For instance, POLG1 mutation is characterized by sensory neuropathy, but may present with a CMT-like picture for years before developing all the other symptoms. And also MING may mimic CMT at presentation. And this paper, this review on Lancet Neurology by our group came out this week. All these features are reviewed there. I mentioned that there are several genes associated with disorder of axonal transport that are a cause of CMT, and also membrane trafficking. Probably not relevant for the number of patients involved, but for the number of genes, number of proteins, and interest of metabolism is very interesting. Now, this is not to frighten you, but to tell you how can be complicated the diagnostic process for molecular testing now. This is a tentative flow chart for demyelinating CMT. We start from the application. Then, if there is a male-to-male transmission, go to connexin 32, GJB1. MPZ is another important gene. Then there are other genes associated with dominant forms, and a huge list of genes associated with the recessive form. That is very challenging, but you may have some clue based on phenotype, on clinical phenotype. Now the future that is already available in a few laboratories is the targeted gene panels. With one shot you can run the DNA of the patient with a panel covering all the gene for CMT, or different panels, gene for demyelinating and intermediate CMT, or for axonal CMT for motor forms, and with 2 or 3 shots you can cover all CMT genes. So this is the future in the clinical approach to diagnosis of this neuropathy, when and where it is available, of course. And the same is true for the axonal or intermediate sensory motor CMT. Mitofusin 2 is the most important for dominant types. GJB1 for females may present as CMT type 2. MPZ, late onset axonal neuropathy. GDAP1 is important here in Spain also for dominant cases. And other genes, you can suspect them based on clinical phenotype, more motor involvement, pyramidal signs, predominant upper limb involvement, vocal cord involvement, and so on. And the same is true for the recessive forms. But again, the future is on the targeted gene panel and exome sequencing for research. There are several cellular and animal models to study the different forms of CMT, and they have been very important to design the therapeutic approach. I will show you very briefly ascorbic acid later on, which was a failure for CMT1A. It was unsuccessful. We know that progesterone antagonists are able to downregulate PMP22. That is the therapeutic option for trying to treat CMT1A that is due to the overexpression of PMP22. And the problem is that these compounds are still too toxic to be tested in vivo in the human disorders, but they proved effective in the animal model. There's a project of in the States funded by the American Association of CMT Patients with high throughput screening, shown this morning for Huntington, Korea. They are testing several compounds in cell culture overexpressing PMP22, and to try to identify compounds able to downregulate PMP22. Different compounds have been identified, and some of them are being tested in the animal models. Another approach is to regulate the unfolded protein response and the endoplasmic reticulum stress response, which is both mechanisms appear to be important for mutation altering the trafficking of the protein within the cell, particularly for myelin proteins, particularly for MPZ and PMP22. And curcumin is probably the next drug to be tested in human trials, because among the different actions is able to regulate the unfolded protein response, and this is active in some of these mutations. So this is a possible therapeutic option. Another interesting mechanism is that related to histone deacetylase 6 inhibitors, which prove very effective in a mouse model of CMT2 or distal hereditary motor neuropathy. And they were able to revert the axonal transport deficit present in these animals. So theoretically, it might be very interesting for different types of CMT with axonal transport defects. Another pathway is that of neuroregulin 1 type 3, which is very important for regulating the thickness of myelin. You can induce hypermyelination or hypomyelination, and with drugs there's a possibility of interacting with this pathway to revert hypermyelination or revert hypomyelination. So this could be a potential therapy for HMPP, which is hypermyelinating neuropathy, or demyelinating hypomyelinating neuropathy. There are other compounds able to act on GABA-B receptor, which appear to be beneficial for the rat model CNT1A, and also there is evidence that these P2X7 receptor modulators are active in a cell culture model of CNT1A, and they are being tested now in the animal models. And finally, we must keep in mind that what we can really do for this patient now is rehabilitation therapy, which is effective, as shown by some trials of a few years ago, and there are now other trials ongoing in Italy, in UK, and elsewhere, in Australia as well. Therefore, it's very important to be able to conduct clinical trial in a proper way, and this is the number of trials conducting fluoroscopic acids all over the world. All were negative. We, in Italy and UK, ran the largest and longest trial with 271 patients treated for 2 years, but all the trials were negative. Anyway, we have learned a lot of things from these trials, which were the first large-scale trials in CMT. We had a lot of information on disease course and outcome measures. We know that the current measures are not responsive enough, as we will probably see in the next presentation as well. Therefore, we do need further natural history studies. Any trial must be of sufficient long duration and recruit a sufficient number of patients to have sufficient power to see an efficacy of treatment. Therefore, multi-center studies are fundamental, and networking is fundamental. We need reliable and more responsive outcome measures to see whether a drug is effective. We need biomarkers, and we also are developing a CMT registry on an international base to be ready to recruit patients with different mutations according to the drug we have the possibility to test in clinical trials. And in international effort, we have done some work to develop clinical outcome measures, and we now have 2 composite clinical outcome measures, one for the adult patients, which is the CMT neuropathy score, and we revised the first version and the second version according to the results of the trials with ascorbic acid, in the attempt to make it more sensitive to change, more responsive. There's a very good scale for children, pediatric scale, developed by Burns in international collaborations, which is rather time-consuming, but is very, very nice and correlate with disease severity with other outcome measures. And we are testing the responsiveness over years in both scales. In our trial, the most responsive measure was the foot dorsiflexion myometry with this device stabilizing the foot. This is very important because strength of the foot is important for CMT patients. This is likely to be clinically meaningful. A change in strength foot is likely to be clinically meaningful. That's important to be borne in mind. Also, we are studying other measures such as the 6-minute walking test in CMT patients, and also the activity monitors, which are devices like this one, able to quantitate the motor activity over a certain period of time, used in muscle disorders, and we are translated into neuropathy. Very quickly, paraclinical outcome measures, we are studying gait analysis because which is computerized. We can analyze the dorsiflexion and plantar flexion of the foot during the during the gait cycle, and also foot and heel, toe and heel walking. And we are trying to identify early abnormalities in children, and if we can measure a change over time. MRI, we have shown from the lesson from muscles, and we will see later on from neuropathy, as in beautiful studies by Jose. We learned that we can see muscle denervation even in neuropathy, in CMT, which is progressive from the foot up to the leg and the thigh. And in London, the group of Mary Riley is trying to develop a quantitative measure using the 3-point Dixon technique to see whether it can be used as an outcome measure. Eventually, biomarkers. Blood can be a source of biomarkers. Skin biopsy may be a source of biomarkers because we do have myelinated fibers in the dermis, the skin. And very briefly, I will show in the trial, we examined the skin biopsy in baseline and after 2 years of treatment in 45 CMT1A patients, equally distributed in placebo and ascorbic acid, to see whether it is true that ascorbic acid is able to downregulate PMP22. We measured its messenger RNA, and to see whether there was a correlation with other outcome measures. In collaboration with the Genova laboratory led by Angelo Schenone, we didn't see any change of PMP22 in skin biopsy messenger RNA. Ascorbic acid does not downregulate PMP22. Here we see that there is no change with respect to baseline for any PMP22 variant. This is the variant related to the expressed in the nerve. And also we found no correlation with outcome measures. So PMP22 in skin biopsy is not a good biomarker. We do need other biomarkers, and Michael Sereda in Göttingen is looking for other potential biomarkers in skin biopsy and also in blood. And I conclude by saying that we do need to cooperation effort like are you doing here in Spain. We have a good cooperation in Italy with my institute and also different groups in Italy, but also internationally with particularly with Mary Line in London, Mike Shai in the States, Josh Burns in Australia, Michael Sereda in Göttingen, and also with Jose and Francisco Palau here in Spain. And I would like to thank all of you for your attention. Thank you very much. Muchas gracias.
Thank you very much for this excellent presentation, open to discussion. Are there any questions from the audience? Yeah, Xavier?
Proteins or innervation for follow-up, but what about diagnosis? It has not been used in hereditary neuropathies, and you may get access to see if there is demyelination, no myelination, even distinguish different type of sensory fibers. What do you think? Is there any prospect future?
The problem is that you can get very few fibers with the skin biopsy, not many of them. You can perform some morphology and you will see the same abnormalities that you see in the nerve biopsy. I mean, you catch small myelinated fibers, and it depends on the type of CMT. For instance, in CMT1A, small myelinated fibers are mildly involved. There are studies studying the internodal length to see whether it's different, reduced, on the, trying to make some correlation with CMT type. I don't think there is nowadays room for diagnosis or morphology for this, but a lot of potentiality for studying metabolic pathways, proteins, and biomarkers, and so on, more than diagnostic.